So once we get the technical things nailed down, we really do want to be fast and furious about this, because what we're going to try to do in a very brief period of time here is to give you a distillation of about several decades worth of research on what we know is effective in helping people quit smoking and stay quit in the long run. So, a couple objectives here, kind of like the old joke. We're going to have some bad news, we're going to have some good news, and I'm going to tell you right up front, we're mostly going to sidestep the questions about vaping or e-cigarettes, although we can handle some of that during the question and answer period that we have at the time, partly because we've got limited information, scientific information about that, but also because I really want this to be focused in terms of what you will be applying to that case study that you're going to have for 2 weeks from now. And we will have questions at the end. Because people are in different rooms, we're going to shift those around. So we will start by taking questions from those of you here in the auditorium, and then we will move on to take questions remotely from 1321, and then from room 1331. I think we've lost our reverb. Outstanding. Thank you for that. Okay, so why do we care about this as healthcare providers? Well, there's an incredibly painful and obvious answer to that, and that is nearly 500,000 people die just in the U.S. alone every year. And you can see from this that mostly that's caused by heart disease, by lung cancer, and respiratory diseases, particularly chronic obstructive pulmonary disease, plus a fraction. And that's just in the U.S. If you've ever looked at the projections by about mid-century, what's projected to happen in China in terms of deaths, which is probably about 50, 60 years behind the U.S. in mortality, they're absolutely staggering. Another way to think about that is consider cigarettes as a product. When they are used as directed, they are going to kill about 1 in 2 long-term smokers. So when you're thinking about interventions, things that you can do with your patients to improve not only the length but the quality of their life, nothing else even comes close to this. On average, people who are regular dependent smokers are losing between 13 and 14 years of their lives. And that's something that I'm hoping, based on what we talk about here over the next couple weeks, you're going to find yourself better equipped to help them take that time back. We have actually made some progress. When you look back to the middle 1950s, when the U.S. government first started to track the incidence and the prevalence of smoking, you can see it was almost 50% of adults. And in fact, if you split that out and we're looking at men, it was over 50% because there was a pretty big gender gap at that point. Over time, it has slowly but gradually come down to the point where at the most recent national data we have, it's just under 14%. In Wisconsin, we're not doing quite as well. We're at about 16% at the equivalent point. But again, we've made progress in tandem with what's going on nationwide. Unfortunately, like so many other things in life, this progress has not been equally distributed. And in particular, we've identified 4 different groups that continue to smoke at elevated rates compared to the rest of the population. And this is something that I want to focus on a little bit, because simply by virtue of being here in this auditorium taking this course, you all are in an educated bracket that has smoking rates of less than 10%. Just based on the fact that of your degrees, you add on the healthcare element and it goes down even further. So in some ways it's easy for us to think of this as some kind of weird alien experience if you don't smoke, if you hardly know anyone who smokes. And yet, among people who are poor, among those who have the least amount of formal education, among those that have mental health or substance disorders that are comorbid with their smoking, and certain racial and ethnic minorities, the progress is not there. We've got 8.4 million smokers below the poverty level. These are the folks that have the least access to effective treatment, the things that we know help people quit and stay quit. When you look at, I want you to think back just a couple slides when we were looking at that gradual decline since the early 1960s in smoking rates. If you break that out by education level, people whose formal education ends before they graduate from high school, that line is almost flat since the 1960s. It's as if almost nothing that we have learned in medicine and health science about how to help people quit smoking has gotten to that population. They also start at higher rates as well. If you break it out by people with comorbid mental health diagnoses, you can see across the board there somewhere between about 10 to 14 percentage points higher rates of smoking. And again, this is aggregating across all diagnoses. If you cherry pick a little, particularly people with diagnoses of schizophrenia or other psychoses, some of those smoking rates approach 80, 85%. They're huge. Similarly with substance use disorders, you can see here from 2015 to 2017, almost tripling the rates of smoking prevalence in people with other substance use, whether that's alcohol, opiates, or other drugs. And then finally, to break that out by some of the racial ethnic categories that the federal government tracks, you can see that there has not been dramatic change in the 21st century in terms of how various groups are, but consistently we're seeing much higher rates among American Indians and Alaskan Natives, and that has been true going back into the previous century as well. So again, get that sense of who is it in 2019 that's still smoking, who's at highest risk when you're starting to encounter people in your clinical training. All right, well, let's switch from the somewhat grim epidemiologic data and put these things in perspective. We have one big advantage, and that is in any given year, about 35% of the people who smoke will make a serious quit attempt. And we also know from doing exit interviews in primary care clinics that they overwhelmingly say the most important factor in them making that decision to have a quit attempt is advice from a clinician. What's not so great about it is, even given all the work that's been done over the last couple of decades trying to identify and then disseminate the most effective smoking cessation treatments, still 70 to 80% of people, when they try to make a quit attempt, they go cold turkey. Easy to say, funny to make fun of in an ad. There's a series out there that you may have seen if you've been watching television of late. Anybody in the auditorium want to take a stab? If you take 100 people who get up morning of New Year's Day with that very common resolution, I'm going to quit smoking this year, and they do it by crumpling up their pack and throwing it away and deciding no other intervention, I'm just going to stop smoking. If we check in with those 100 people at the end of the year, New Year's Eve, about how many of them do you think are going to still be non-smokers a year later? Yes? We have the optimist branch over here. Actually, you're very close. It's about 5%. So definitely within round-off error. Yeah. It's a spectacularly inefficient way to quit. And it's also uncomfortable for people. Nicotine withdrawal is much more unpleasant than it needs to be. The good news is we can do a lot better with that. When we offer people who are willing to make a quit attempt counseling and medication, that combination produces quit rates at 1 year that, depending on what the combo is in the population, get that into the range of 10 to 40%. So by doing a little bit of intervention, we can really help people achieve much better outcomes with this. So how do we do that, and how do we know what? I'm going to lean really heavily on this publication from the Public Health Service, the Treating Tobacco Use and Dependence Clinical Practice Guideline. And this came out most recently in 2008. But the core parts of it are still current and state-of-the-art now. What the PHS guideline recommends is this mnemonic called the 5 A's. And that is, at every clinical encounter, we ask people about tobacco use. Do you use tobacco or not? If they do, then we advise all users in a brief, clear, personalized way to quit. This is the tricky part, and this is a bit of history trivia for you, but the original version of the Clinical Practice Guideline only had 4 A's. You all are getting the extra bonus updated edition with 5 A's, because what was missing initially was listening. Listening to patients, assess whether they are willing to make a quit attempt at this time. If they are, then we assist them. We go ahead, we provide those evidence-based treatments that we've already touched on, and finally we arrange follow-up. And if you're more of a visual learner, this is kind of a flow chart, but you see the ask down. Everybody that uses gets the advice. We assess by asking, by listening, and then we either follow the branch to assist with counseling and medication for those who are motivated, or if they're not, then we do a brief motivational intervention. I'm not really going to dwell on that part because that's really not part of the case that you're going to be working on over the next 2 weeks. All right. So, because this is all about roles and responsibilities, what do we know about different types of clinicians doing interventions? And the meta-analyses that the guideline is based on all takes these kind of formats. So there's a comparison, which would be no clinician intervening at all, and that we arbitrarily set the reference odds ratio to 1. And we're comparing that to what happens if you just hand people a self-help pamphlet. All right? That actually doesn't make a difference. This is slightly better than our reference group, but the confidence interval overlaps 1.0, which means it's not reliably different. What does matter, though, is if you have non-physician clinicians, and I apologize given that you all would fit into that heading, but the meta-analysis didn't let us tease things out to more specific detail. But nurses are in there. Pharmacists are in there, physician assistants, psychologists, God help us. They're all in there, and compared to physicians. And you can see both of those groups are highly effective, just about doubling people's chances of quitting when they are the ones providing the intervention. And it gets better, because we also did another meta-analysis looking at what happens when people are getting this intervention, when they're getting this message about effective ways to quit from multiple clinicians. And again, here you see the reference is not hearing anything from anyone, set to 1. When people get that message about the importance of quitting from one clinician of any type, you can see there's a big initial impact that jumps up to 1.8. But when you start hearing that from multiple people within the healthcare team, there's even more synergy going on. 2.5, an effect size of 2.5 is pretty powerful in terms of increasing people's chances of quitting successfully. So there, I hope you take that takeaway when you're thinking about how you apply this to the case. How do you get that synergy? Who are the different parts of the team that are able to contribute to that kind of outcome? So in terms of a brief clinical intervention, I want you to think about a number of different factors as you're looking through the case with Mr. Morris. Part of it is definitely the brief counseling. And that's going to depend on the environment that you're in, the capacities of the patient you're working with, and also the amount of time that you have. At the most basic, if you're in a clinical encounter with someone who is motivated to make a quit attempt, at the absolute least, don't let them leave that encounter without setting a quit date. Right? That's sort of the bare minimum, because if they walk away with just a vague good intention to quit smoking, that's what it's going to end up being in most cases, a vague good intention. help them make that into a specific date. If you have the time, you can ask about their past experience. Really, unless you're dealing with a pediatric population, it is really unusual to find an adult smoker who hasn't tried to quit at least once before, and they usually can learn from that, or you can help them learn. When you're talking to somebody who has tried to quit 4 times before, every single time they relapsed when they were out drinking with friends, and yet have never made the connection that, maybe that's a high-risk situation. You can help them make that connection. Think about, ask them to think, what is going to be difficult for you to do without smoking? Most people can rattle off 3 or 4 urge triggers without even thinking about it, right? When they first get up in the morning, when they get in the car, at their break time at work, after a meal. Alcohol, especially here in Wisconsin, is a huge, even though the bars have gone smoke-free, something I thought would never happen in my lifetime, still, it's a contributor to well over 50% of relapses. And also the challenge of trying to quit when there's someone else in the household that smokes. Social support is the second element that the guideline has found increases people's chances of success, and particularly when it's in the clinical context. So here is where the team being involved, encouraging and supporting patients in their quit attempts is a vital part of it, and to communicate that to people. We're here to help you. This is a goal. We can work with you on that. And I think all the different professions that are represented in this course have different ways of coming at that. And then the last factor that increases people's chances of success, as we've seen already, is medication. So I want to spend a little bit of time on that, even knowing that some of you are not in roles that are going to have you dealing directly with medication. But even if you're not deciding, what should be prescribed or what someone's treatment regimen is going to be, knowing what those medicines are, how they work, and how to use them effectively is something that the whole team contributes to. Before we get into the details, I do want to point out that the guideline was very clear that there are some populations where we don't have an evidence base that suggests that there is no benefit to people using. That would include children and adolescents, even if they're regular daily smokers. We don't have good evidence that it increases their chance of success. Light smokers, which at the time meant people who smoked fewer than 10 cigarettes per day. That's actually a little bit of a moving target, because one thing we've seen in recent years is as cigarettes become more expensive and as there are more and more places that you just can't smoke, people are smoking fewer cigarettes per day, even though they may not ideally want to do that. People who use non-cigarette, and here I'm going to throw in vaping at the moment because we don't have scientific evidence that any of the smoking cessation medicines help people get off e-cigarettes either. But certainly people who chew, who use spit tobacco would fall into that. And women who are smoking while they're pregnant. Again, we don't, in the US, there isn't solid data. There's some foreign studies that suggest that may not be true, but they're pretty limited at this point. Okay? So, in terms of the medicine, one of the things you're going to be doing over the next 2 weeks is looking at the Center for Tobacco Research and Intervention's website. In there is a cheat sheet that lays out all the particulars of the FDA-approved smoking cessation meds. So I really want to urge you to look at that carefully to see, what the treatment regimens are. But this is amazing, and partly this is because I'm a dinosaur, but when I started out, we had nothing to help people. It was cold turkey, and we really even didn't know that much about what was effective for counseling. Now, the FDA has approved 7 different medicines to help people quit. There's a little bit of a cheat. If you look at this carefully, you can see 5 of those 7 are actually different ways of delivering nicotine. And that's kind of the paradox. Because the thing about smoking, all those deaths we were looking at before from heart disease, from cancer, from COPD, they are not caused, for the most part, by nicotine. That's the delivery system of combustible tobacco. What keeps people coming back for the next dose and the next dose and the next dose is the nicotine. So as far back as the 1980s, in the treatment side, we were thinking, is there a way we can give people nicotine, reduce their withdrawal symptoms, reduce their craving, without exposing them to carbon monoxide and tar and carcinogens? And what you see here with these 5, the gum, the inhaler, the lozenge, the nasal spray, and the patch, are all, imperfect solutions to that. But they deliver nicotine, they reduce withdrawal and craving, they increase success rates, and they decouple the pharmacologic effects of nicotine from the activity of smoking a cigarette. Bupropion and varenicline are the only non-nicotine meds that have been approved in the U.S. by the FDA. And to a certain extent, they're both working on a mesolimbic reward system in the brain. Varenicline in particular is kind of funky because it has a mixed agonist and antagonist effect. That's good. Nobody screamed and ran out of the room. No chemistry flashbacks. This is good. So it provides some withdrawal symptom relief the way nicotine does, but because it is much more specific to the alpha-4 beta-2 nicotinic receptor, it also blocks a lot of the rewarding properties of smoking. And for some people, that makes them more likely to be able to quit than they would be just using nicotine replacement therapy. Okay? So these are the things that go into our pharmacologic bag of tricks. Again, think about these when you're considering the possibilities that you have with the case with Mr. Morris. Are there some of these that are going to be easier for him to use? The gum, the patch, and the lozenge are all available over the counter as opposed to the prescription meds, which are the others. That may have implications about how likely someone is able to use or to pay for the medication. Think about those mechanisms of action. Is it something people use as needed? Or is it kind of a fire and forget, like putting a patch on and not having to think about it for 24 hours? And I mentioned before, but there's a really strong case to be made that we need to combine both counseling and medication. And you can see here's another one of the meta-analyses where we're looking at counseling alone as our reference standard. And if we add medication to that, again, we're almost doubling people's chances of success. So whenever possible, you want both of those to be part of the treatment plan. Right? Quit lines are another thing that you want to bring into your treatment plan when you're thinking about who will be doing what. If we have our comparison here as minimal or no counseling, or that much vilified self-help pamphlet, you can see that when people have access to a telephone quit line, that's increasing by over half again their likelihood to quit. And we are very fortunate in Wisconsin that we have a great quit line. We've had this now for almost 20 years. But just outside of the parameters of the course, if you know anybody that would benefit, this is available at no cost to anybody in the state. It's a toll-free number. People don't have to go any farther than where their phone happens to be. And in addition to the telephone-based counseling and support, it also provides 2 weeks of either nicotine patch, gum, or lozenge to people who are willing to quit. If you don't like to use the phone, which I hear is a keen, trendy thing these days, there are other options as well. And the National Cancer Institute in particular has gone all in on web and text-based things. So we have smokefree.gov as a website. It's optimized for social media and mobile phones. It's also specialized with content for women, for teens. There's a Spanish language version of it. There's one for veterans. There's one specifically focused on helping women quit during pregnancy. And then these are pretty much all replicated in terms of an automated texting program too. So you can talk to people face to face. You can have them pick up their phone and call the quit line. You can have them ignore that part of the phone and use the web or texting services. All of those are out there as treatment multipliers for you to use in conjunction with your team. All right? So to wrap this up before we go into the questions, I just want to put a couple things in your mind. Think about with the team, with Mr. Morris here, who's going to have the discussion about medication based upon role. And this isn't necessarily one and only one of the professions, because other people may have input on it. Does he know how to use the selected medication correctly? How does that fit into those plans for coping with urges after his quit date? Those are all things that are those multipliers of more than one clinician talking. Who does the counseling? You know, this is not counseling in the sense of a formal C. You don't have to do years of psychoanalysis for someone to quit smoking effectively. Brief, focused, problem solving, or what we call coping response training, is what's most effective in helping people quit. That simple act of asking someone, hey, when you feel stressed, what are you going to do instead of picking up a cigarette? Who's providing support, and how do the different members of the team implement that? There's a role that everyone has a part to play. And finally, I want to leave you with one particular question, and that is, when you're thinking about the case with Mr. Morris and looking at all the details on that, what motivates that critical question of how does someone's decisional balance tip to decide to make a quit attempt, knowing that it's not easy? And particularly for those of us who are kind of embedded in the healthcare universe, it is really easy to think in terms of health consequences, right? Because that's there for us every day. And as I was putting this together, I was thinking about someone that we saw in our smoking cessation clinic a number of years ago. It was actually this time of the year. It was a woman that had come in. She was really motivated, like she wanted to come in the same day that she called us. And she had to wait a few days, but we got her in. And I had the ability to look at her chart ahead of time. And I could see that there was some family history of cancer there, which would be a really good reason for someone to quit. She had a few personal markers of cardiac risk. So before I even met her, my mind is going, okay, here's someone that's quitting for their health. That's good, because that's one of the strongest predictors of success. And then she came in, and we started talking. And for a change, I actually listened to what someone was telling me. And for her, it had nothing at all to do with health. The day before she had called us to come into the clinic was a miserable October day, not like today, but just barely in the 30s. It was raining. She was going to pick up her grade school-aged kids after school. As she was driving there in the cold rain, she realized that she was running out of cigarettes. So she pulled into the Quickie Mart to buy a pack, right? Because if you're dependent on cigarettes, you don't go without. You don't run out of them. And then she headed off. And for whatever reason, her kids that day, instead of standing inside the building, were waiting at the curb for her to pick them up. And she said as soon as she came around the corner and could see them standing there in this cold, miserable, soaking rain, she felt like the worst parent ever. Because in her mind, the reason that happened was because she had stopped to buy cigarettes. And that's why she was frantic and on the phone and wanting to quit. So listen to what people are telling you in terms of their motivation. And I think as you go through that case history, you're going to find there are some things in there that are hooks motivationally that you can make use of. Okay? So this is our website, which I think you're all going to be visiting at least once or twice over the next couple weeks. Make use of any resources that are there. And I think at that, we're...
Okay. Any questions here in the auditorium before we go to the other classrooms? Just raise your hand. Okay.
I was just curious, is there a difference in efficacy with the different nicotine options?
and whether there's an efficacy difference between the various nicotine replacement therapies. Yeah, if you look at the odds ratios in the guideline, there's a range. From nicotine gum, it looks like the least effective. It's got an odds ratio of about 1.5, all the way on up. The problem is that those were tested in variable groups. So we have a ton of research looking at nicotine gum and nicotine patch as pharmacotherapies. Nicotine nasal spray and the inhaler, not so much. So if you're just looking at the odds ratios, those may look like really powerful effects, and they're probably over-exaggerated based on a small sample. Plus, in a lot of cases, the biggest driver is just what's available. You know, what's covered by the insurance formulary for a particular patient. What are they willing to use? The nasal spray is actually really close in terms of pharmacokinetics to the bolus you get from inhaling on a cigarette, and yet it's really not user-friendly. There are a lot of people that will not squirt nicotine solution into their noses because it's very irritating. So there are those trade-offs, but that's a great question.
Any other questions here?
That superb question, and it's one we can't totally generalize about because, you know, one person's crisis can be, but that's something that our center has been working on pretty hard over the last 5 years, in that there's a lot of superstition and inertia, particularly on the behavioral health side of things, that people shouldn't make changes, that you know, being functional is very precarious. And as a result, you see those incredible smoking rates that we saw in the epidemiologic slides. It's not a complete answer, but the best one I can give you is back in the 1990s, the U.S. had a huge unplanned naturally occurring experiment in that the Joint Commission that, you know, certifies healthcare organizations in the mid-90s decided, okay, hospitals, clinics, you're all smoke-free, is sending the wrong message if people can smoke while they're in a hospital. And they specifically carved out exceptions for facilities that were exclusively psychiatric or substance-based treatments, okay? In reality, because a lot of those programs were, you know, in a fully functional hospital like we have here at UW, very few places took advantage of those exemptions. So inpatient psychiatry units, inpatient residential treatment went smoke-free because the whole institution was, and it was just easier to implement. What happened after people started to look at outcomes were that they were no worse at all. So even people that were going through you know, behavioral health crises that landed them in hospital, even people who were going inpatient for substance abuse treatment, particularly in the case of the latter, actually did better. They were more likely to quit the substance they were being treated for, as well as quitting smoking. So the takeaway from that is, based on the evidence that we have, not necessarily for every specific case, but in general, that's probably not something with a lot of validity to it.
So I guess 1321 does not have any questions. I just got a note. But if 1331 has any questions, if they can send me a chat so we can get those answered. So it looks like no questions from the other two rooms. Are there any other questions here in the auditorium before we finish up?
Thank you, everybody.